Xin mời một cái mảng cũng rất là hấp dẫn, đó là vấn đề về cột sống, thần kinh cột sống ạ. Mời báo cáo viên Trần Trung Kiên với cái tên đề tài là phẫu thuật cố định cột sống ít xâm lấn và giải ép gián tiếp trong chấn thương mất vững cột sống vùng ngực thắt lưng. Xin mời báo cáo viên.
So thank you very much for welcoming me in here. It is my honoring to be here to introduce our new research. So our new research is focused on the surgical in percutaneous pedicle screw and the decompression in the unstable thoracolumbar fracture. So we have five main points. And the first one I want to say that I would like to say thank you for Professor Tontetbach. For Professor Tontetbach is have us in 2003. He has created a spinal unit so that we can learn a lot about this. And Dr. Nguyễn Văn Thạch also. And if Dr. Bach and Dr. Thạch helped me a lot in teaching me in the first step in spinal surgery, and Dr. Kiều Đình Hùng is helped me to create how to bring a very good life for the patient. And if you know that in 2019 in Hanoi Medical University, we do only 85 MIS case. In 2020, we do about 200 cases, and this year because of the COVID criteria, but we still increase the number of the MIS case into more than 200 cases. And once again, I want to say thank you to Professor Hùng. In the historical, the percutaneous pedicle screw was first created in 1984. This is external fixation, and because of this external fixation, the quality of life of the patient is very good, very bad, because he has to stand in mostly the bed and not so movably. And it takes about 60 years. In the 2000, we just learned how to put on the rod in this two percutaneous, and this is create a very big number of the MISK in the world and in the Vietnam also. As we created this study with two main points, and you can see that this is for the open surgery, so it's damaged for the tissue a lot. So we increase the technique to put on the screw percutaneously with the two point. The one is evaluate of the reason of the minimally invasive, and the second is the safety in this kind of surgery. So we have 20 patients with the criteria this unstable fracture at the thoracolumbar area, and for the exclusion is for the osteoporosis and in the very severe cases. And we collect all the information from the patient, and we do X-ray regularly and CT scanner, and of course an MRI in some cases. And this, on X-ray we measure on the kyphosis angle. We measure on the head of each vertebra. And on the CT scanner, we focus on the canal stenosis. And we use the criteria of this to have the very good evaluation for the pedicle screw on the CT scanner. And this is all the way we focus on the kyphosis angle. This is the head of the vertebral body and the screw and the canal stenosis. So how to do the reduction? So how to do the reduction? We use this. Cái này nó không viết lên. Okay. So we do the hyperextension of the patient. So if you can see that this is an X-ray of the pre-operation, the angle is very kyphosis. But when we put on this hyperextension position, the the vertebra go to likely to normal. And other way we can use the screw to have the extension after the surgery. And how to put on the screw in the right direction. The first one we use a jump CD needle. So this is very normal needles. But now we use this kind of needle with the 3.5 millimeter. We can measure on the situation in here, and if we put on with equal spaces, so we cannot go further into the canal. So this is very safe needle now we use today. So this is all the criteria is focused on the result. We use the SPSS 23rd software, and this is ethical medication. So on the result, on the normal age, the average age is 54.5 years. Mostly the patients stay in the hospital for 3 days. The most level we see is on L1, and we use 170 screws. So this is the result between the pre-operation and post-operation. For the nerve damage, after surgery, all the patient was recover pretty well. For the lumbar kyphosis, this recover about 62.9%. For the lumbar, for the canal stenosis, all the patient recover about 62.2%. And for the vertebral head, the patient recovered mostly in more than 61%. So another study, we found that we can use another pillow below this kind of fracture. And on the patient in this kind of situation, we use very forced reduction. So on the spinal, or the surgeon is put on the very force in here, so all the vertebrae will extend it. So mostly, we can say that for the critical for the percutaneous pedicle screw is on the fracture is more than 50% of the head. And we have the extension of the posterior ligament complex, and with the kyphosis is about 30 to 35 degree. And with all of these criteria, we can say that the patient has the posterior ligament compressed defection and very high risk at canal stenosis. So another way to use, if the patient has the canal stenosis, we use the MIS canal to have a very good reduction release. And for the normal case, we use only for 46 minutes. And another study suggests they need about 105 minutes to do all the cases. And if we have the comparison after we use indirect decompression with the percutaneous, also we see a very big difference of this study. And now in our study, we use 170 screw with the best places about 89.7%. At the BC group, it's about 6 to 4.3%. And on the screw didn't cause any nerve damage. So this is K1, so it's very severe kyphosis. And after we put on the position on the kyphosis, it's recovered. So we use a hyperextension position, and this is for pre-operation, and this is post-operation. In the next case, we do the same procedure, and with the screw to extend on this area of the fracture vertebra, and we do the CT scanner before surgery. You can see that's very severe canal stenosis. But after 6 months, we do the CT scanner on this stenosis, it's gone. So I just want to say that we can not definitely prevention for the spinal cord injury, but we can always do the best for the patient. And once again, thank you for the MIS procedure to help the patient recover quickly and short time for hospitalizing. Thank you very much.
Thank you your presentation. And now please, Professor Hùng, about your comment and question.
Cái này thì báo cáo thầy lệnh với thầy là cái này thì cũng các bạn này có một cái sáng kiến là những cái bệnh nhân chấn thương cột sống mà nó bị gù ấy, có chèn ép ấy, thì thay vì trước kia mình mổ mở, mình mở cung sau ấy, thì các bạn ấy kê tư thế nó nắn lại, rồi sau để bắt vít qua da chứ không phải mở rộng nữa, thì nó cũng vừa nhanh mà nó vừa đỡ đau cho người bệnh, nó vững hơn, cột sống nó vững hơn. Đấy là cái sáng kiến của các bạn ấy. Tôi hỏi anh một câu là trong cái nhóm của anh làm thì có những cái trường hợp nào mà anh không nắn được mà anh phải quay ra anh mổ mở không?
Vâng, rất cảm ơn câu hỏi của thầy Hùng. Đối với các trường hợp mà em nhận thấy là đối với trường hợp xẹp quá 50% thân đốt sống, hoặc là trong trường hợp mà có hẹp thân đốt sống trên 30%, đây là theo các nghiên cứu hiện tại thôi ạ, thì những cái trường hợp này thì em sẽ không đưa vào nhóm nghiên cứu. Nhưng tuy nhiên có một cái phương án là đối với trường hợp hẹp trên 30% thân đốt sống thì em vẫn có thể sử dụng ống nong để em giải phóng chèn ép thần kinh được. Vì vậy nếu mà có nhiều thời gian trong cuộc phẫu thuật thì em nghĩ là tất cả các chấn thương cột sống có chèn ép thần kinh thì đều có thể làm qua cái phương pháp bắt vít và cố định qua da này, rất là tốt cho người bệnh. Và thông thường các bệnh nhân của em thì chỉ đến ngày thứ 2 là có thể đứng dậy đi lại được.
Cảm ơn các thầy, có hỏi gì thêm không ạ? Cảm ơn em ạ. Tiếp theo